Okay, let's dive into this. Have you ever had that like persistent ringing in one ear that just feels off?
Or maybe moments where you just feel weirdly off balance, almost like the ground's tilting a bit.
Exactly. And sometimes these really subtle things can actually be the first signs pointing towards something quite specific.
And, well, when those symptoms send you down a bit of a rabbit hole of medical info, that's kind of where we step in.
Absolutely. So today we're tackling a topic that's often pretty crucial for anyone studying medicine or healthcare. We actually got these revision notes from a listener.
Ah, okay.
Yeah, and we're going to do a deep dive into acoustic neuromas. Basically, our mission here is to take these detailed notes and turn them into something really clear, high yield.
Strip away the noise. Focus on the must-know facts.
Right. Whether you're prepping for an exam, maybe like the MSRA, or you just want to get a better handle on this condition.
Think of it as like your shortcut to understanding the core ideas behind acoustic neuroma, pulling out the really important bits from the source material we have.
Perfect. So let's start right at the beginning. What exactly is an acoustic neuroma? I mean, the absolute basic fact here is that it's a benign tumor.
Right. Benign, that's the key word, means it's not cancerous. And it comes from a specific place, Schwann cells.
Schwann cells.
Yeah, they're the cells that make the sort of protective layer, the sheath around nerve fibers.
Okay, Schwann cells, got it. And these particular ones are acting up on one very specific nerve, right?
Precisely. It's the vestibulocochlear nerve. You probably know it better as the eighth cranial nerve.
Ah, the eighth nerve.
Yeah, and this nerve is absolutely vital. It handles two critical senses, hearing and balance.
Okay, so the eighth nerve is like a two-lane highway carrying signals for both hearing and balance to the brain.
Exactly.
So it makes total sense that a tumor popping up there is going to mess with both of those things.
That's it. Now, the source notes flag some really key features. It's typically slow growing, which fits with it being benign. It usually hits the balance part of that eighth nerve highway first, the vestibular part, but the hearing part, the cochlear part, gets involved too. The real problem isn't the cancer aspect, it's the physical space it takes up.
Mass effect, they call it.
Exactly, mass effect. As it grows, it literally starts pressing on things nearby.
You know, I'm guessing it's a pretty crowded neighborhood in there. How big can these actually get?
Well, they can get up to about 4 centimeter, maybe a bit more, within this really tight spot at the base of the skull. It's called the cerebellopontine angle, or CPA.
4 centimeter. Wow, that's like, what, a large grape? Or a small golf ball?
Something like that.
Yeah.
And imagine trying to squeeze that into an area already packed with vital nerves and bits of the brainstem. So, yeah, mass effect isn't just a technical term. It's the physical reality of this thing pushing on everything around it.
Okay, that paints a clear picture. And you said typically slow growing, but I noticed the source material adds a really important point here. Some can grow rapidly.
Yes, that's a critical nuance. Some might even double in size within 6 months. It's not the norm, but it happens. And it really highlights why monitoring can be so important.
Definitely. And another key point from the notes about prevalence, usually unilateral, right, just on one side.
Usually, yes. But, and this is a crucial distinction, the notes make bilateral cases, so tumors on both eighth nerves, are very strongly linked to a specific genetic condition.
Which is?
Neurofibromatosis type 2. NF2?
NF2.
NF2.
Okay, that sounds like something we need to remember. So if we dig into why someone might get one, what do the notes say about the causes, the risk factors?
Well, the etiology, the actual origin, it's mostly uncertain for most cases. The general thinking is it's probably some mix of genetic mutations happening spontaneously and maybe some environmental factors. Most are just sporadic.
They just happen.
They just happen, yeah. No clear inherited pattern for the majority.
But then there's that NF2 connection we just mentioned.
Exactly. A small but really significant percentage are linked to NF2. The notes describe NF2 as an autosomal dominant disorder. That's the main established genetic link, and it's the big player behind those bilateral acoustic neuromas.
And you see those earlier in life, typically.
Often, yes. The notes mention NF2-related cases tend to present earlier, often around age 30.
And there's a point about genetic screening, too, for really young patients.
Yeah, if someone presents with symptoms very early, say under 20, the notes suggest considering genetic screening for NF2. Makes sense, right? You want to identify that underlying condition if it's there.
Absolutely. So drilling down on confirmed risk factors from the source material, what are they?
It basically boils down to two main things. One, having a family or personal history of NF2. 2, having had high-dose ionizing radiation exposure, particularly to the head area.
Okay. What about things people often worry about, like mobile phones? Do the notes mention that?
They do, and it's important to be clear on what they say. The source classifies the evidence linking mobile phones to acoustic neuromas as limited.
Limited, okay.
Yeah. So while some studies might have suggested a possible link, it's definitely not confirmed or established like the NF2 or radiation risks are. The notes are quite specific about that difference.
That's a really useful clarification. Thanks. Oh, and there was also a note about psychological impact, something about symptoms linking to anxiety and depression.
Yes, that's mentioned. It makes sense, really. Living with ongoing symptoms like hearing loss, tinnitus, balance problems, they can be unpredictable, affect your daily life, so it's understandable that it can increase the risk for anxiety and depression.
Yeah, that makes sense. Okay, so we know what it is, roughly why it might happen. How does this benign tumor in that specific spot actually cause the problems?
Yeah.
Let's talk pathophysiology, the mechanism.
Right. So it all starts with those Schwann cells on the 8th cranial nerve. The core process is just gradual tumor growth.
And that growth leads to?
Compression. Simple as that, really. The main way it causes symptoms is by physically squeezing the 8th nerve itself. That disrupts the hearing and balance signals. But because of where it is that crowded CPA junction, it's not just the 8th nerve. As it gets bigger, it can start compressing adjacent structures too. Other cranial nerves, blood vessels, even parts of the brainstem.
Ah, okay. So it's like that traffic jam on the 8th nerve highway, spilling over and blocking the nearby roads as well. Which other nerves tend to get squeezed?
The notes specifically point out cranial nerves V and 7.
Right. V is the trigeminal nerve facial sensation, and 7th is the facial nerve facial movement.
Exactly. So pressure on nerve V explains things like facial numbness or tingling, maybe that absent corneal reflex the notes mention where touching the cornea doesn't trigger a blink.
Okay.
And pressure on nerve 7 explains facial weakness or palsy difficulty, smiling, closing the eye, that kind of thing.
Got it. So the underlying biology involves genetic mutations, changes in cell signaling, but crucially, it doesn't spread.
Correct. The notes state it's non-metastatic. It doesn't travel to distant parts of the body like a malignant cancer might. All the trouble it causes comes down to its size and its location in that critical CPA spot.
All right, it's all about the real estate. Speaking of which, who tends to get these? How common are they? Let's look at the epidemiology.
Okay. The notes give some UK context. The estimate is around 1 case per 100,000 people each year.
So fairly uncommon overall.
Relatively, yes. In terms of all intracranial tumors inside the skull, they make up maybe 5% or perhaps 6-8% according to the source. It varies slightly.
But within that specific location, the CPA.
They're the dominant player. The notes say they account for about 90% of all tumors found specifically in the cerebellopontine angle.
Wow, okay. So if you see a growth in the CPA on a scan, an acoustic neuroma is definitely the prime suspect.
Very much so.
And age-wise, who gets them most often?
The peak incidence, the most common age range, is typically between 30 and 60 years old.
Okay. Let's pull this together then and talk about what someone might actually feel or notice. The clinical presentation, the symptoms. What are the big red flags? The cardinal signs.
Right, the notes are clear on this. The most common first symptom is usually gradual, unilateral hearing loss. Often it starts with high-frequency sounds. People might notice they have trouble understanding speech, especially if there's background noise.
Okay. One-sided hearing loss. What else?
Tinnitus is very common, that ringing, buzzing, hissing sound just in the affected ear. And then dizziness or a feeling of unsteadiness, like imbalance. Actual vertigo, the sensation that the room is spinning, can happen too. The notes also mention difficulty with fine motor tasks, which is interesting.
So those are the core 8th nerve symptoms: hearing loss, tinnitus, dizziness, maybe vertigo. But what happens as the tumor grows and starts bothering those neighbors, nerves Z and 7?
That's when you start seeing the other set of symptoms kick in. Facial numbness, tingling, or altered sensation, that's nerve V, the trigeminal, maybe that absent corneal reflex we mentioned, and facial palsy or weakness, that's nerve C, the facial nerve. So difficulty controlling facial muscles, maybe a droop on one side.
So often it's hearing imbalance first, then facial sensation or movement issues if it gets bigger.
That's a common progression, yes. And with very large tumors, you can get headaches because of increased pressure inside the skull. And although it's rare, the notes mention potentially life-threatening complications from severely increased intracranial pressure.
Okay. And just hammering home that NF2 link, again, bilateral symptoms are the big clue.
Absolutely. If someone presents with these kinds of symptoms on both sides, NF2 immediately jumps way up the list of possibilities you need to consider. It's a critical diagnostic flag.
Got it. So with symptoms like these, which, as you said, aren't totally unique,
Hmm.
how do doctors sort it out? How do they know it's an acoustic neuroma and not something else? This brings us to the differential diagnosis.
Yeah, it's a good point. Unilateral hearing loss, dizziness, other things can cause that. The notes list several conditions to keep in mind.
Like what? What else could it be?
Well, Meniere's disease is a big one. That's an inner ear issue causing vertigo spells, fluctuating hearing loss, tinnitus. Middle ear infections can cause hearing issues. Otosclerosis, that's where there's abnormal bone growth in the middle ear affecting hearing. And other types of tumors need to be ruled out, especially things like meningiomas if they happen to be near the CPA, or other rarer ear tumors.
So a few possibilities. How do they actually nail the diagnosis? The notes mentioned a key tool.
Yes, the definitive test, the key tool is magnetic resonance imaging, MRI, specifically an MRI with contrast dye.
Why the contrast?
The contrast helps the tumor light up on the scan, making it much easier to see clearly. The MRI is fantastic because it doesn't just show the tumor, it shows its exact size, its precise location, and crucially, how it relates to all those important nearby structures, the nerves, V7-8, the brainstem, blood vessels. It gives you the whole picture. It's the gold standard.
Okay, MRI with contrast is the decider. What are the first steps, though, if you suspect it based on symptoms?
Usually, the first steps involve testing the function of that eighth nerve. So, audiometry is key. That gives a detailed picture of the hearing loss. Is it that typical high-frequency sensorineural pattern? How's their speech discrimination?
Testing the hearing properly.
Exactly. And vestibular function tests to check the balance system. How well is that side of the eighth nerve working?
So symptoms lead to functional tests, audiometry, vestibular tests. If those raise flags, then the MRI with contrast.
That's the typical pathway. And if the suspicion is high after those tests, the next step, according to the notes, is an urgent referral to an ENT specialist, ear, nose, and throat. They're the experts who manage these conditions.
Makes sense. The notes also mention a couple of other tests, ABR and ENG.
Yes, auditory brainstem response, or ABR. This test checks how the electrical signals travel along the auditory pathway, including the eighth nerve. It can sometimes be used as a screening tool in lower-risk patients or as part of the workup. And electronystagmography, EMG, another test looking at balance function by measuring eye movements.
Okay, so audiometry and vestibular tests first, MRI for the definitive look, ABRing as potential supporting tests, all leading to that ENT referral. Got it. So once it is diagnosed, what then? How do you manage acoustic neuroma?
Right, management. The notes really stress that this is highly individualized. There's no single best way for everyone.
Depends on the person and the tumor.
Exactly. It depends heavily on the tumor size. Is it growing? How fast? What symptoms is the patient having? How severe are they? What's the patient's age? Their overall health? All these factors go into the decision.
And who makes the call?
It's usually a multidisciplinary team, an MBT. So neurosurgeons, ENT surgeons, radiation oncologists, audiologists, neurologists, they all weigh in. The notes also mention that in the UK, this care is typically provided in specialized NHS centers.
Okay, an MBT approach. Makes sense for something this complex. What are the main options on the table that the team will consider?
The source lists 3 main strategies. First one is observation.
Just watching it. When would you do that?
Yeah, sometimes called watchful waiting. This is often a good option for, say, older patients or people with significant other health problems who might not tolerate active treatment well. Or maybe for very small tumors that aren't growing much and are causing minimal symptoms.
So it doesn't mean doing nothing.
Not at all. It involves regular MRI scans, maybe yearly or more often, to carefully track the tumor size. And providing support for symptoms, like fitting hearing aids if there's hearing loss.
Okay, so option 1. Keep a close eye on it if it's small, stable, or the patient isn't a candidate for more invasive stuff. What's option 2?
Surgery. The notes mention a microsurgical approach. This means surgeons use powerful operating microscopes to do very precise work.
And the goal is removal.
The goal is usually to remove as much of the tumor as safely possible. Often, a key aim is also trying to preserve hearing function if there's still useful hearing left. But it's delicate surgery in a really tricky spot.
Right, near all those crucial nerves, so risks.
Significant potential risks, yes. Damage to the facial nerve, nerve 7, is a major concern that can lead to permanent facial weakness or paralysis. There's also a risk of hearing loss, even if they try to preserve it. And CSF leaks cerebrospinal fluid leaking out, which can lead to things like meningitis or bad headaches. Paralysis is mentioned as a risk too, though less common.
Okay, so surgery aims for removal but carries real risks, especially to nerve function. What's the third main option?
Radiotherapy, specifically a technique called stereotactic radiosurgery, or SRS, sometimes called gamma knife or cyber knife.
That's not cutting, right? It's radiation.
Exactly. It's not surgery in the traditional sense. It uses many highly focused beams of radiation, all converging precisely on the tumor from different angles. The goal here isn't usually immediate removal, but rather to stop the tumor from growing, or at least slow it down significantly, while, again, trying to preserve hearing and facial nerve function.
And what are the potential downsides or risks with SRS?
The notes mention risks like radiation-induced damage to the surrounding healthy brain tissue, that's brain necrosis, and also potential injury to those nearby cranial nerves, V7/8, because they're right next door to the target. There can also be some swelling initially.
So three main paths: observation, watch; surgery, remove; radiotherapy, zap. Each with its own pros, cons, goals, and risks. The notes also flick at some emerging treatments.
Yes, briefly. They list some biological therapies, drugs like bevacizumab, everolimus, lapatinib. These target specific molecular pathways involved in tumor growth, often particularly relevant in NF2 cases. And interestingly, the notes mention that aspirin might potentially slow tumor growth.
Aspirin. That's really fascinating. Didn't expect that. Okay, last big section. What's a long-term picture? Prognosis and what complications can pop up.
Yeah, prognosis. The outlook really varies from person to person. It depends hugely on things like how big the tumor was when it was found, how fast it was growing, the person's overall health and which treatment they had, and how well it worked.
Is there good news overall?
Generally, yes. The notes emphasize that finding it early and getting the right management leads to better outcomes. Effective treatment can control symptoms, it can help prevent further hearing loss in some people, and it can definitely improve quality of life.
But, as we just covered, the treatments themselves have risks.
Absolutely. That's a key takeaway. The notes reiterate that both surgery and radiation carry potential complications. Things like permanent hearing loss, facial nerve damage causing weakness or paralysis, and ongoing balance problems are real possibilities.
So complications can come from the tumor itself just growing, or from the treatment used to stop it.
Exactly. The list of specific complications in the source covers both hearing loss, facial nerve issues, balance problems, CSF leaks, which can lead to infection like meningitis, and then less commonly, infection itself or hydrocephalus, which is that fluid buildup in the brain. Many of these overlap with the treatment risks we just discussed.
And how do the medical teams try to minimize these bad outcomes?
Close monitoring is key, according to the notes, whether that's during the observation phase or following up after surgery or radiation. And carefully selecting the most appropriate treatment strategy for each individual patient is crucial for minimizing risks and maximizing the chance of a good long-term outcome.
Okay, so let's try and wrap that all up. An acoustic neuroma, the benign, non-cancerous tumor, starts from Schwann cells on the 8th cranial nerve, that critical nerve for hearing and balance.
Right. Its main problem comes from its location in the crowded cerebellopontine angle, where its growth causes compression mass effect. This hits the 8th nerve first, causing hearing loss, tinnitus, balance issues, but it can also squeeze its neighbors, especially nerves V and 7, leading to facial numbness or weakness.
Most are sporadic, just happen. But there's a really strong link to NF2, especially if you see them on both sides. Diagnosis. MRI with contrast is the gold standard. Usually after hearing and balance tests flag up a problem.
And management is totally individualized. Could be observation with regular scans. Could be microsurgery aiming for removal. Could be stereotactic radiosurgery aiming to stop growth. Each has benefits, but also significant potential risks, like hearing loss or facial nerve damage.
Understanding these key points, what it is, why it happens, how it presents, how it's found, and how it's managed, is really vital if you're trying to learn about this condition, whether that's for exams, clinical work, or just general knowledge. These are the high-yield takeaways.
Definitely. These are the core facts you really need to have locked down.
It really is fascinating, isn't it? How something technically benign can cause so many complex problems just because of where it grows in that incredibly important tiny space.
And how medicine has developed these quite different strategies, watching, cutting, zapping to try and deal with it, each with its own kind of trade-off. The precision needed is incredible.
Absolutely. Now, if you are deep diving into this for revision, getting these facts straight is obviously key. And resources specifically designed for that kind of medical revision, like passthemsra.com and freemsra.com, can be super helpful.
Yeah, those kinds of resources are great. They quiz you on exactly the sort of high-yield information, help you practice retrieving it, make sure it sticks.
Using tools like that definitely helps cement the concepts we've talked through today. Make sure you can recall them when you need to.
Definitely check them out if you're serious about your revision for exams like the MSRA. They're built for mastering topics just like this one.
Absolutely recommended.